My name is Courtney Funderburk. I am presenting a case study on a particular infectious disease that we encountered at Benefis Hospital at the end of 2014. Please use the Word document that I attached to my posting, as it gives detailed objective, subjective, and diagnostic workup findings for each encounter this patient had. Patient history. This patient's a 57-year-old male who lives in Geyser, Montana. He is a cattle rancher. He owns and operates his own cattle ranch. Has hyperlipidemia, gout, hypothyroidism, history of BCC on the left cheek, and bacterial meningitis 30 years ago, which he acquired while working in Argentina. Takes allopurinol and levothyroxine. Statins and penicillin are his allergies. Social history is benign except for some social intake of alcohol and 2 to 4 cups of coffee per day. He was first seen in primary care at the beginning of September of last year for some upper respiratory symptoms that he had been having for the past 2 weeks: cough, sinus pressure, postnasal drip. Also had some intermittent flushing of the face associated with diaphoresis. He had a mild elevated temperature at this time with some tachycardia, and his skin was pretty ruddy. A CBC showed elevated monocytes, which they did not have any explanation for. Put this patient on prednisone for the flushing of the face and the cough, and augmentin for the sinuses. Patient follows up a week later. The cough got better well on the prednisone for 5 days, but came back and actually was worse after the prednisone was finished. New symptoms of shortness of breath and myalgias are now present. The fever has elevated to 101.5. Wheezes are now heard, and the labs now show decreased lymphocytes and atypical lymphocytes on a smear. Prednisone taper was started, and albuterol inhaler was given for shortness of breath, and Robitussin with codeine cough syrup for this cough. Was seen in dermatology for the flushing of the face, but also the patient reported that he did have some sort of rash on his chest, which he couldn't explain. At the time of the dermatology office visit, however, that rash was not present. Therefore, the dermatologist could not work it up. So the dermatology encounter did not find anything. Patient seen in primary care at the end of September. Sinus pressure and postnasal drip are worsening. The cough has improved slightly after the prednisone taper, but is still present. The fever has come down slightly, but now he has tenderness over the maxillary sinuses. The tympanic membranes are retracted, but without erythema or swelling. Wheezes heard in the upper lung fields, but they have improved after the prednisone. Now he has elevated white blood cells, elevated CRP and ESR indicative of inflammation, elevated bilirubin, and his TSH was elevated greater beyond what's his baseline. They started him on levofloxacin for the sinuses and ordered a CT of his sinuses, which came back normal. Seen in primary care at the beginning of October. States the albuterol helps a little with the shortness of breath. The temperature has come down now after the levofloxacin. Objective findings were pretty unremarkable, other than his cough worsens with forced expiration and talking. EKG done just to rule out any heart issues. They sent him to pulmonology. Pulmonology didn't really find anything other than the PFTs did suggest some reactive airway. They put him on Spiriva 2-Dorza and QVAR samples and told him to check his peak flows, as they believe it is some sort of airway reactivity, maybe due to some chemical exposures out on the ranch. Seen in primary care in mid-November. Just a note, this patient did go to the Yucatan Peninsula in Mexico for a month with his wife, they do this every year. He did not feel very well, so as soon as he got off the plane, he was in the clinic. The sinus congestion, pain, and pressure still persists. Now there's a thick purulent drainage that is visualized in the posterior oropharynx and in the nares. The tympanic membranes now have some edema and redness. The tenderness over the sinuses persists, and now he has some lymphadenopathy. Continue him on the levofloxacin and add Mucinex D for the congestion. Seen again in primary care in mid-December. He now presents with some neurological symptoms of shakiness and dizziness with head movement. The dizziness is worse with head and eye movement, but is not related to any positional changes. He does have one beat of lateral nystagmus with side-to-side head rotation, and he has some left gait deviation. Also of note, this patient's wife did know that he had difficulty signing his check and also was starting to forget things that had occurred within the past 6 months. They did start him on antivert as no treatment was indicated for the diagnosis of acute vestibular neuritis. The very following day, the patient was admitted to our Benefice ICU because he had a seizure while he was eating at a restaurant with his family. His temperature in the ER was 104.5, after which they intubated him to protect his airway due to multiple seizures. CT, MRI, EEG were negative. Keppra and fentanyl were started for the seizures. However, the seizures persisted for 13 hours throughout the night of admission, which finally ceased in the morning. Lumbar puncture showed some elevated white blood cells, of which 100% were lymphocytes. Glucose was normal, proteins were elevated. Broad spectrum antibiotics and acyclovir were started for bacterial and viral meningitis. Consult to infectious disease and neurology done. Antibiotics were discontinued after the culture of the CSF came back negative. Fungal culture was negative. Blood and sputum cultures were negative. Patient was extubated and sent home on the 20th with a diagnosis of viral meningitis of unknown etiology. Patient was discharged home on Keppra and a fentanyl taper. Down below are the list of infectious organisms that were all ruled out during this hospital stay. The patient follows up with his primary care provider at the beginning of the year. No seizures since discharge. However, he still has a lot of fatigue. He is napping frequently throughout the day. PE and vital signs within normal limits. The labs still remain abnormal. However, at this time now, the patient does have some elevated liver enzymes. The AST, ALTs, and alk phoses were all elevated. This is a new finding. However, they did not make any note of it because it could possibly be from some of the medications that he was put on while in the hospital. Followed up with primary care roughly a week later. He had been completely tapered off his fentanyl, is only on the Keppra now, and he had a seizure on the 9th of January. At this time, they restarted the fentanyl. The very following day, they went to the ER because the patient kept having seizures. He had some right upper extremity abnormal movements, postictal headache, photophobia. All diagnostic workup remained unchanged from the first hospital admission, CT, MRI, EEG. Lumbar puncture was exactly the same as the first hospital admission. During this hospital stay, they ruled out Hep B and Hep C, which they did because of the elevated liver enzymes and leptospirosis. Patient was discharged home on the 19th of January, and they are considering a Mayo Clinic or Swedish Medical Center referral for a second consult. Patient follows up with Dr. Geyer in infectious disease after his hospital visit. Dr. Geyer at this time believes that viral meningitis is less likely due to the fact of the length of time this patient has been symptomatic, which has been several weeks to a month, which is very typical for a viral infection. The patient also reports that the redness of the skin from umbilicus to the vertex of the scalp is persisting, associated with headache and diaphoresis. At this time, Dr. Geyer has run out of workable diagnoses, and he is referring this patient to the Mayo Clinic for a neurological infectious disease workup. The patient goes to the Mayo Clinic in Rochester, Minnesota. These two tests that I put down were two tests that we do for this particular infectious disease. His TEE was abnormal, but they could not tell whether the abnormality seen on his valve was a vegetation or a Lamble's excrescence. However, the gold standard, the kind of key to the case was these IgG serologies were elevated to this specific microorganism's antibody. So at this time, using all of the data that you have on that handout, try and formulate a diagnosis for this patient. On the next slide, I will reveal the diagnosis. This patient was diagnosed with Coxiella burnetii, also known as Q fever. The serologies that were run against the C. burnetii antibody showed IgG elevation greater than 100 to phase 2 antibodies. The patient did not have any phase 1 antibody elevation. For reference to phase 1 and phase 2 variants of the C. burnetii organism, please use my quick tips handout that I gave you on how this organism works. The final diagnosis was acute Q fever and Q fever meningoencephalitis. They did start him on doxycycline and hydroxychloroquine for 1 year. The typical treatment for just acute Q fever is 2 to 3 weeks treatment of doxycycline. However, due to the fact that this patient had an abnormal TEE during his workup at Mayo, they prophylactically added the hydroxychloroquine and extended it out for 12 months because any valvulopathy presents a very high risk for the development of chronic Q fever. The patient will be followed by Mayo and infectious disease for the next year, having frequent workups of his IgG serologies and echocardiograms. If at any time this patient starts to have an elevation of IgG antibodies to the phase 1 antibodies, they will extend the treatment out to 18 months, which is recommended for treatment of chronic Q fever by the CDC. So this patient actually had a very typical presentation for Q fever. The temperature, the headaches, the myalgias, chills, fatigue, photophobia, and sweats. The fever did not resolve on its own. Actually, the addition of the levofloxacin was the key that brought the fever down for this patient. But ironically enough, fluoroquinolones are indicated for treatment of Q fever if doxycycline cannot be used. However, it's not as effective as doxycycline, and it was not prescribed in the dosing manner that was indicated for treatment of Q fever, which is why the patient never got better. This patient had the typical upper respiratory symptoms, which is typically seen in North America. In Europe, they have the hepatitis symptoms, which he did have the elevated liver enzymes. So he was actually displaying a lot of the symptoms that were indicative of acute Q fever. The meningoencephalitis is actually one of the other possible outcomes of this acute Q fever. However, you will only see this in less than 5% of patients that have acute Q fever. The chronic Q fever, this patient does not have the chronic Q fever at this time, but however, they are going to keep a very close eye on him as he is at risk for developing it with his abnormal TEE. Again, for any further information on this on C. burnetii, please refer to my quick tips that I did post in a Word document on my presentation. If you have any questions, please feel free to post them to my discussion. And I did list all of these diagnoses of Q fever for laboratory and diagnostic workup. Again, the phase 2, phase 1 IgG serologies are the gold standard for diagnosis, as well as using clinical signs and symptoms. Again, if you read through any of the references I posted here, no two cases of Q fever will present exactly the same. In fact, the symptoms are very vague, and thus it's a very hard infectious organism to diagnose. However, looking at the risk factors for this patient, he does work around cattle, which cattle can be one of the carriers of C. burnetii. But actually what they concluded was this patient contracted this organism while shoveling out a sheep shed where they birthed sheep for one of his neighbors. Placental fluid and tissues actually have the highest concentration of C. burnetii in infected animals, which is why he was probably in a very concentrated source while helping clean out this sheep shed. the interesting thing about this is once it's shedded from the animal in either urine, feces, or placental birthing tissues and fluids, it can actually form a spore and live in the dirt and the dust environment for up to a year, but also travel up to a mile away via the wind, which he lives in a very windy environment as well. So they concluded that he contracted it from that particular spore source in the form of a spore from the dirt environment. Please use these references if you have any more questions about Q fever or any of its clinical manifestations and diagnostic workup. Thank you.